this was meant to be a talk that we were going to do for the final FRCA teaching, but I was sick, so I couldn't do it. So I thought I'd just move it to today. So there's it tries to cover some of the syllabus for the curriculum. So hopefully it's useful, but probably goes into a lot of detail that you don't need. So don't worry too much about it. So the aim is really to recap the basic cardiac electrophysiology, because that's always useful. And if you go back to first principles, everything's straightforward to understand. Talk a bit about the pathogenesis of arrhythmias, because that then means that we can understand how we treat them, approaches to management, and then we'll touch a bit on antiarrhythmic medications. But this isn't just a talk about listing lots of medications, because you can read that in a book. So a bit of a disclaimer, I'm not a cardiologist. I'm definitely not an electrophysiologist. Don't forget the basics, because most of the time that's more than enough. And as I said, this is more than what's required for the SOE. So on the face of it, it sounds like quite a boring topic, and it obviously can be. So lots of audience participation. So there's four victims in this room. But if anyone online wants to ask anything, just start talking and interrupt me. It's absolutely fine. Syllabus point of view, I must admit the anaesthetic syllabus is a bit difficult to find, for one, and then actually work out what you need from it is quite a challenge. And it's all very vague, but these are sort of the things that I found that would be vaguely relevant to this talk. And likewise, once we've talked about this, if people want to send me a CBD or something, we can do that. If it covers helps, I don't mind. Okay, so bit of a recap on the basic electrophysiology of the heart. Who wants to talk?
We could start with the SA node, and then pass to the AV node, then through the ventricles, and then the Golgi fibers through the ventricles. And what I know also is the impulses in the node must pass from the innermost level to the outermost level.
Okay.
That's my focus.
Yeah. So I'll just recap what's been said by Bas here, just in case people can't hear it. So yeah, you're absolutely right. Impulses generate in the sinoatrial node, or most of the time generate in the sinoatrial node. They do then pass directly across to the right-hand side by something called Bauchmann's bundle. Okay, so there is something that connects the atria together. But the most classical teaching that we hear of is you've got impulses generate in the SA node, travel down the His-Purkinje system, down to the apex of the heart, and then they split into the bundle branches. So you've got two on the left, one on the right. And you get depolarization from the apex upwards. You get a ringing motion of the ventricles rather than it contracting the other way around. Then blood obviously wouldn't eject from the heart, and that's the basic physiology of it. The impulses are generated at regular intervals, so the SA node generates an impulse at around 100 beats per minute. It's always under the control of vagal stimulation to slow it down, and the SA node is at the junction between the SVC and the right atrium. Okay, so that's roughly where it is. Is that all fair enough? Okay. We're going to talk a little bit about the cardiac action potentials and the two different types, and that obviously then leads us on to what we think about in terms of management. But I think one thing that I just wanted to point out, and I think this is really key. Do you like my play on words there? Cations. Do you get it? No, cations. Wasted on you. Okay. Okay. So I think if you could appreciate where the main ions are and where they're at their highest and where they're at their lowest, you can work everything else out. And I think this is why it's important to understand really basic physiology, because the rest of it is easy. Okay, so you can just see I've done like this classic thing that Mercedes do, where they try and hide something in a different color. So you've got sodium down here, potassium and calcium. Okay, and they're the main three that you need to think about. All right. So if you think about the main extracellular cations and their concentrations, what are they and where are they? Well, I've told you they're sodium, potassium, and calcium, but where are they at their highest concentration and lowest concentration? So where's sodium highest? Intracellular or extracellular?
Sodium is usually extra.
Correct.
Yeah. That's usually intra.
Yeah, exactly. So that's the key first thing to remember. So you've roughly got the same concentration of sodium as you have potassium, but they're in opposite locations. So the main concentration of sodium is extracellular, which is about 135 to 145 milliequivalents, whatever you want to, millimoles, doesn't really matter. Potassium, the same, but intracellular. Okay. The other one is calcium, which is quite important for cardiac. So mainly extra or intracellular.
So
it's mainly extracellular in terms of its free free fraction. So it's about 8.5 to 10 point something extracellular. Intracellular is very, very small, but then it's all bound inside of sarcoplasmic reticulum, etc. So that's why it's low. Okay. So there's potential for intracellular calcium to be high, but under physiological situations, it's low. All right. So that's key. Everyone happy with that? Good stuff. So that makes understanding the rest of it much easier. Okay, so this is a unashamedly stolen picture of the action potential, pacemaker action potential, but I have referenced it, so if anyone wants to use it, they're welcome. And this splits it down into these three stages, which I'm sure people will have seen before. Okay, now I could never really understand when this is taught why they always seem to start at phase 0, mainly because that's probably where it comes in the numeral scale. But actually, if you think about it, you better think of it starting from phase 4. Okay. So we said it's under constant vehicle control, it's automated, and it's rhythmic. Okay, and these are key things to understand. Now, one of the key differences between the pacemaker action potential and the cardiac action potential is what? Automaticity. But if you think about the shape of it, what? There's no plateau, and
it is
yeah, so there's no true resting membrane potential. Hey, James. Yeah. Okay. So if we think about phase 4, or we think of the end of phase 3 into phase 4, what do we know about channels and things? What's going on there? Bearing in mind we just spoke about where the ions are at their highest.
social, so that we can make that change.
Okay.
Toxic.
Sort of. I'm just trying to minimize this thing. But there we go. Okay. So I don't know if can you see my pointer? No. Okay. So if we look at the end of phase 3, at the start of phase 4, so you can go from the beginning of the graph. The resting membrane potential is around minus 60 millivolts. Okay. You've got potassium channels closed and non-specific sodium channels open, leading to an inward current of sodium. Okay, so you've got an inward current of positively charged ions. So you're going to make the membrane potential go from a negative value more towards a positive one. Okay, now that process is rhythmical, and that's why there's no continuous resting membrane potential. Okay, and this is this funny current that you'll have heard of. So the funny current channels, it's predominantly sodium. There are some potassium channels in there as well. Okay, but it's easiest just to think of it as sodium. Now that is happening all the time. So you've constantly got inward generation of sodium, and that's why it's rhythmically, why it's got rhythmicity to it. Now, in terms of that upslope, what happens in phase 4 is around 50 millivolts, you get opening of one type of calcium channels, which is the T-type calcium channels, which is transient. And then when you get to about minus 40 millivolts, as it's constantly depolarizing, you get opening of the L-type calcium channels, which causes further depolarization. All right. So that then leads us on to phase 0, so where the line changes from blue to orange. Okay, and that's when you've reached threshold potential. So in the pacemaker action potential, that's about minus 30 millivolts. Okay, and at that point, you get opening of all the calcium channels. Okay, which means that the membrane potential goes from very negative to very positive quite quickly. Okay, and alterations in the opening of those channels will change the angle of that slope, which then we'll talk about a little bit later. All right. You get opening of all the L-type calcium channels, sorry. So during this slope, all of the funny channel current closes and all of the transient calcium channels close, okay? Which leads us up to the beginning of phase 3, which is repolarization, okay? Which is where all the calcium channels close and you get inward rectified potassium channels open, which means that they actively move potassium out of the cell, in the cell in order to return the membrane potential back to a negative point, okay? And that's essentially how that works. Is everyone happy with that? Yeah. Can't see anyone's hands, so okay. Yeah. Comes out again. Yeah. Yeah. Okay. So in terms of regulation of pacemaker activity, I mean, this is key in terms of how our heart rate is controlled physiologically, isn't it? So as we mentioned, intrinsically, you've got an automatic rate of around 100 beats per minute under constant vagal suppression. And you see that in patients who've had vagotomies or have had cardiac transplantation, or you give atropine to, essentially blocking that vagal stimulation, and therefore the heart rate goes up. Now, in terms of things that can alter that regulation of pacemaker activity, you've got these 6 things here. Okay, so changes in autonomic nerve activity. Now that makes sense, doesn't it? So all we're doing there really is altering the angle of the phase 4 slope, so you reach threshold at a quicker rate, which means your heart rate goes up. All right. And the way that you do that is by altering the funny current, and you open the slow calcium channels. Okay, that's what changes that. Steeper the slope, the more sympathetic response you've got, the faster the heart rate will be, and the opposite for parasympathetic. Okay. So if you drop that slope, it takes longer to reach threshold, slows down the heart rate. Yeah. Hormones. You think of all of the positive hormones, they work in the same way. Okay, they affect the funny slope, essentially. Cellular hypoxia. Fantastic. Yeah. So there's some thyroxin's a main one you can think of. There's lots of others I can't think off the top of my head, but yeah, thyroxin's a good one to go with to kick off with. So yeah. Yeah, cellular hypoxia, so you're absolutely right. So the resting membrane potential, or sort of semi-resting membrane potential, is maintained by sodium potassium ATPase. So if you've got cellular hypoxia, you don't generate any ATP, so you can't maintain that. Okay, and therefore, if you can't maintain that, you approach the depolarization part at a much earlier time point, and therefore you can get tachycardia. And likewise, to do various things to do with the handling of calcium when you've got hypoxia, that then changes it as well. Serum ions, as we've said, you have to have the concentrations appropriate in the intracellular and extracellular compartments. And if you change those, then you'll change what the resting membrane potentials are because of the Nernst equation, which you've all sort of remember, I hope, but don't need to know. Drugs we'll talk about later because that's obviously the point. And then age. So age has actually quite a strong impact on pacemaker potential. So it was the old thing that you'd measure what your absolute maximum heart rate was by 220 minus your age. There's other calculations you can do for that, but the main thing is that age affects your pacemaker potential. Okay, right. And then moving on to this is the cardiac action potential. So again, you can start where you like. To me, it makes sense to start at the flat bit, which is phase 4 again, and then think about the other parts. Okay, and there's some other differences we'll talk about very briefly in here. Now, unlike pacemaker cells, these clearly have a true resting membrane potential, okay, which is maintained by the sodium potassium ATPase, which we've already said. Okay, so at resting membrane potential, it's near the equilibrium potential for potassium, right? Because via the Nernst equation, and that's around minus 90 millivolts. Okay, so in phase 4, potassium channels are open. As we said, that's what maintains the resting membrane potential, and the sodium and calcium channels are closed. All right. Phase 0, what happens? Exactly. So fast sodium channels, sodium rushes in, and then you rapidly reach around minus 70, which is the threshold potential. Okay. At which point, fast sodium channels open, potassium channels close, and you get the resting membrane potential approaches that of sodium. Right, which is why it's very, very positive. And that's the resting membrane potential according to the Nernst equation for sodium. Okay, so this is the key difference in this part is the plateau phase, which is to do with calcium, which isn't flat because you've constantly got repolarization happening during that point, but it's prolonged due to the effects of calcium. Okay, so in phase 1, you do get initial repolarization, so there is a drop in the line from the beginning, and that's to do with opening of potassium channels. Okay, as it tries to approach back towards its resting membrane potential. You get closure of the sodium channels, but you get opening of calcium channels. Okay, and that's what maintains that depolarization for a period of time. All right. Phase 2, you've got lots of L-type calcium channels open, and you've got potassium channels open as well at the same time, which is why it's not flat. And then phase 3, you get closure of calcium channels with continuous opening of potassium, and that's why it comes down towards back towards its true resting membrane potential. Okay. The key things are this absolute refractory period and relative refractory period. So what does that mean? What's happening there?
Absolutely. There is no chance for another stimulus to come and start initiate frequency or initiate action potential of the muscle while they're refractory. So you reach the resting member potential which need to be reached, but at that point, another stimulus can happen with the risk of having arrhythmias actually at that point.
Yeah. So that's right. So in an absolute refractory period, there is no possibility of another action potential happening. Why is that?
But at that point,
Thank you.
I think the calcium is already opened and the threshold, not much, but I think the threshold is too much high because of the iron concentration.
So the key thing for the absolute refractory period is that all the sodium channels are closed and they can't be reopened. Okay, so you can't then make the membrane potential positive again. It can only become negative from that point. Whereas in a relative refractory period, you can open more sodium channels with a supramaximal stimulus. So it is possible to get another depolarization within the relative refractory period, but not in the absolute refractory period. That all makes sense. One thing that I didn't really appreciate, but actually makes a lot of sense in terms of arrhythmias, is that when we think about the action potential, you think about this happening at the same time throughout the heart, but that isn't actually true. So different heart cells or different cells throughout the heart have a heterogeneous in terms of how long this takes, and therefore they all have slightly different absolute and relative refractory periods, which is why you can get stimulations happening in other parts of the heart while they're not happening in another. So classically, the bundle of His has got a longer refractory period than the cardiac myocyte, for instance. Okay, so there are. It's just useful to appreciate that it's heterogeneous. I think that's one of the main things, because it rings up from the bottom. Exactly right. Okay, so a bit about pathogenesis of arrhythmias. We can obviously split it into bradyarrhythmias and tachyarrhythmias. We're not going to really talk about bradyarrhythmias because they're not really what we're interested in from this talk, although clearly very important. But realistically, bradyarrhythmias are due to failure of impulse generation from the AV node or failure of propagation from cell to cell. Okay, that's essentially how they work. We are going to talk about tachyarrhythmias though, and you can think of them originating due to one of these three things. So you can either have enhanced automaticity, which can be physiological or pathophysiological. You can have triggered automaticity, and then you can have re-entry circuits, which I'm sure people have probably heard of. So in terms of enhanced automaticity, you can have normal enhanced and abnormal enhanced. So normal enhanced is all the things you'd usually think of that cause sinus tachy. Okay, so beta adrenergic stimulation, vagolytic activity, hypokalemia, or mechanical stretch. So something called the Bainbridge reflex, which I don't know if you've come across that. You're nodding, so you're going to have to tell me now. Yeah. Yeah, you're right. You're absolutely right. You're right. So you're absolutely right. So it's the link between physiological stretch of the atria and an increase and a reflex increase in heart rate. And the idea is that what the heart is essentially doing is if it gets very, very full, it increases it in order to eject more blood and not become increasingly distended. And that's all the Bainbridge reflex is. Okay. But that is definitely something that you'll see in practice. Because if you give big fluid balls very, very quickly, you'll probably see an increase in heart rate initially to try and overcome that. The other side of enhanced automaticity is abnormal automaticity, and this is where you get things such as pacemaker sites originating from places other than the SA node, myocyte injury, which leads to partial depolarization, and that's again to do with the way that if you've got cells that are damaged, they have a resting membrane potential which is closer to the depolarization potential. And then things like atrial ectopics and ventricular tachycardias come under that as well. Okay, so that's enhanced automaticity. So that's one of the three things. The second, which is slightly more complicated to understand, I suppose, is triggered automaticity. And this is where you get premature action potential happening before the previous one's totally complete. And this is where I think in the relative refractory period. And you can classify these into two things. You've got delayed after depolarizations and early after depolarizations. The thing that I took from this is that delayed after depolarizations are all the things to do with calcium. Because if you've got increased intracellular calcium for whatever the reason might be, whether that's cellular hypoxia, ischemia, drug toxicity, then if you've got a lot of calcium, what's the cell going to try and do in order to maintain potential? It's going to bring sodium in, which is going to depolarize the cell, which means it can depolarize earlier. Okay. And then the other one is the early after depolarizations, and they're to do with potassium predominantly. Okay, and they're the ones that cause things like torsades. Right. And the last one is re-entry. Okay, so the way that I think about this is that under normal situations, you get a wave of depolarization across the myocytes. If you've got anything that stops that wave from propagating, so a blockage in the path, then what the electroactivity will try and do is find a way to route around it. Okay, and occasionally it'll route around it and come back to the beginning again. And that's where you get a re-entry circuit, and it continues to depolarize itself around that circuit. Now that can happen for lots of reasons. Again, ischemia is a classic one. Patch of ischemia, the electrical signal can't propagate through it, and therefore you're at risk of getting re-entry circuits. The other thing is in people who've got congenital re-entry circuits, things like Wolff, Parkinson, White, and those kind of things, where you've got a underlying reason that you can get re-entry of electrical signals around that pathway. Okay, but the key thing is it has to happen when sodium channels can propagate that signal. Okay. Which is useful because it can make you think about what we might use to treat it. Okay, we won't talk in a lot of detail about this, but essentially just thinking a bit about perioperative arrhythmias. They can either be patient related or pharmacological related in terms of things that we do from an anesthetic point of view. And these really is just a description of what the patient related complication is and which bit of the slope it affects, because again, that makes you understand how you're going to treat it. Okay. So we've already mentioned if you've got increased sympathetic activity, that alters the slope of phase 4. So there's things we can do about that. Bradycardias, these kind of things, obviously these are just listed things we see, but if you've got pacing from an area that isn't the SA node, so if it's pure AV node or it's ventricular site of pacing, then again, that can make us think about how we're going to treat it. Ischemia we've talked about, and then electrolyte disturbances. Once you know where the electrolytes need to go, you can work out if you've got a problem, what effect that will have on the action potential. Okay. And potassium is obviously the obvious one. So if you've got very, very high extracellular potassium, then you can't repolarize. So you can't propagate any action potentials, and you'll get bradycardia, and then you'll get asystole. Okay, pharmacological things. So hypnotics all reduce sympathetic activity, and they also attenuate the baroreceptor reflex. So that's another way in which they affect the cardiovascular system, although not strictly speaking the action potential. Opioids, again, in high doses, you see, if you give big doses of fentanyl or Remy, you get bradycardias because of its parasympathetic effect. Anticholinesterase is an obvious one. Vasoconstrictors cause bradycardia because it's a reflex, and there's loads of drugs that prolong QT, pretty much everything, although we never really worry about it. So I think key is don't forget the basics, and I've sort of said that right at the beginning. It's all well and good knowing all this stuff, but actually the majority of perioperative arrhythmias or arrhythmias that we're faced with on the unit, we manage them in the same way, and then we think about the specifics further down the line. And the key things in terms of management are maintain cardiovascular stability, so whether that's rhythm or rate, and we'll talk about that. Treat the underlying cause, because that normally treats the arrhythmia most of the time. Provide hemodynamic support if you need to. Electrical cardioversion is an option if you need it, and then pharmacological management comes right at the end, really, in terms of how you manage these things. And these are just these are the European resus guidelines, but they're exactly the same as the UK ones from ALS. And obviously, we all do that, so we all know how to manage these tachy and bradyarrhythmias in the initial period. Okay, so what are the indications for antiarrhythmic medications? Now, the main things when it comes down to looking at patients in an outpatient setting, and the majority of it is to alleviate symptoms, isn't it? Because patients don't come to you and go, oh, my tachyarrhythmia is really, they feel short of breath, don't they? Or they get swelling, etc. So it's mainly to alleviate symptoms. And the knock-on of that is that you're improving cardiac function. One of the key things from our point of view in critical care is that you prevent any non-malignant arrhythmia to progressing into a malignant one that can cause significant problems. And we obviously want to decrease the need for electrical cardioversion. That's the real reasons that we want to use pharmacotherapy. Okay. Now, interestingly, there's been lots of trials that have looked at the association between antiarrhythmic medications and actually poorer outcomes in patients who are critically ill. So there's a few studies that I just had a look at, and actually some from a while ago, but obviously these are all cardiology studies. They're all absolutely massive in terms of the number of patients that they've got. So there's something called the CAS study, which is published in the New England Journal. And that essentially looked at thinking that if you have patients who've got ventricular ectopics post-MI, you would expect that if you suppress those ventricular ectopics, they're less likely to develop malignant arrhythmias down the line, and therefore they'd have better outcomes. But that was stopped early because in patients who they tried to suppress that in, they had a higher mortality. Okay, so essentially giving flecainide or the sodium channel blockers to patients to try and suppress ventricular ectopics is a bad idea. So we don't do that. So that's one. Exactly. So we don't do that. There's something called the SWORD trial, which looked at giving people sotalol in patients with MI with a low ejection fraction, again, stopped early because it increased mortality. And then the AFFIRM study, which is one to look at AF, which essentially looked at rhythm control and found there was no difference in mortality between the two groups. All that happened when you tried to cardiovert people pharmacologically is that you end up with more complications of giving antiarrhythmic medications, and hence why the mainstay of treatment for us realistically is rate control. Yeah. Yeah.
So what you do is just like look for the cause and start to treat rather than
correct. Yeah. Yeah. So just treat the underlying cause and monitor it. But probably both. I mean, if I saw VEs in theatre, I probably would just ignore it. So yeah. Okay, so what are the aims of antiarrhythmic therapy? So we've already really touched on it, but realistically, we want to suppress enhanced pacemaker activity. Okay, and that's quite easy to get your head around. Prevent triggered automaticity, which is the things that we spoke about. So those delayed after depolarizations and early depolarizations, and then modify any conduction or refractoriness to prevent re-entry tachycardias. Okay, so if we look at this picture, which again I lifted unashamedly from the BGA, there's these four comparisons of how we can potentially manage those things. Okay, so if you have the first one, A, what's going on there? So the green is baseline and blue is the drug effect. Yeah. Yeah, absolutely right. So if you have anything that increases potassium flux, you'll get hyperpolarization of the membrane, which means it's more difficult to get a depolarization. Okay, so that's the first one. B, what's going on there?
The slope is not as steep.
Yeah, so the slope is flatter. So the slope's flatter. Okay, and we know that the slope is predominantly controlled by the funny current, which is sodium channels. Okay, so you can either block them directly, but mainstay of treatment for this is beta blockers.
The black is the normal of
the green one. Oh, it doesn't project very well. That's what's happening, and this is what the drug does.
Okay.
Okay. What about C? Again? Yeah. So what's happening? You're right. Fantastic. Threshold. Yeah. So you're increasing the threshold potential. So you can either block calcium channels because we know that they're involved in that pacemaker potential, or you block sodium channels because obviously they're involved in the funny current. And then D, potassium channels, because this is repolarization, isn't it? So you're prolonging action potential duration, and the only way to do that is to stop potassium from moving. Okay. So the calcium's there anyway, but the thing that causes that downward slope on the action potential is potassium. All right. In terms of it's potassium channel blockers, so you're stopping repolarization. Yeah. The triggered.
You're saying it's the drug action, antiarrhythmic drug action.
Yeah, it's prolonging the action potential. Yeah, exactly. Yeah. Yeah. For the triggered automaticity, the delayed after depolarizations are predominantly due to hypercalcemia intracellularly. So calcium channel blockers do that, and as we've said, beta blockers work via a different mechanism but affect calcium. Okay, so that's how they work. And then in terms of inhibition of re-entry circuits, as we said, the key thing is sodium channels, because you have to have open sodium channels in order for an action potential to propagate. So if you block sodium channels, you'll potentially stop that from happening. All right. Okay, I think that's probably all we'll say about that. So this is this list of medication in terms of how you classify them. Now, when I did this, I'm pretty sure there was only 4, but now there's 8. It was originally the Vaughan William classification, and then it was the Singh Vaughan William classification. So there's now 8 different classes of antiarrhythmics. But if you actually look at this, there's still only actually 5 because the bottom 3 you can't actually have any drugs yet to use clinically. So, but just have an awareness of it. And actually, the way they've broken it down now does make more sense because it's more. There was always that sort of big collection of drugs at the bottom that didn't fit into anything, and now they do. So class 0 is a new one. So this is ivabradine, which is a funny channel blocker. Yeah. So what's useful about ivabradine as a drug? Yeah. Just in terms of its pharmacology, why is it a good drug for managing heart rate? Why though?
Selectively works on the sodium channels rather than the other sodium channels.
That's it. So the key thing with ivabradine is it only actually acts on the channels that control the funny current. So therefore, it has a pure antiarrhythmic property. It doesn't cause any reduction in contractility, which is what you said. So that's why it's a really, really good drug for heart failure because it controls rate without affecting contractility. So yeah, a really good drug from that point of view. And it's got the funny channels have got a very long name, which you don't need to worry about. But just remember that it just affects funny channel current. Okay. So yeah, all class 1 drugs, they're all sodium channel blockers. Yeah, exactly. And they're all classed slightly differently depending on which bit of the potential they work on. Okay, and then they have slightly different uses depending on that. Class 2. Beta blockers, yeah, absolutely right. So they're not all beta blockers, but the predominantly class 2, if you were trying to remember it, would be beta blockers. You've then got muscarinic antagonists as well and agonists, because they both fall into that category for different reasons, and also adenosine falls into that category as well. Yeah, so adenosine is in class 2 now. Don't ask me why. Class 3.
To be fair, sorry, say for digoxin, but digoxin is a 2 also.
Digoxin, it's in 2 because of muscarinic. Yeah, so they've sort of took the big sort of melee of drugs at the end and stuck them all in class 2 instead. But yeah. Okay, class 3 they all prolong the action potential, so they're all potassium channel blockers. Okay, and then class 4, you can see it, they're all calcium channel blockers. Okay, now remember that calcium channel blockers come in 2 flavors. They come in dihydropyridines and non-dihydropyridines. It's the non-dihydropyridines that we're interested in. So things like verapamil, diltiazem, exactly, not the other ones. Now magnesium isn't on there, but we do use that quite a lot. So how does that work?
I guess.
So I think magnesium is brilliant, isn't it? You can use it pretty safely in lots of different scenarios. It's very heavily involved as a co-transporter for lots of other ion channels, particularly sodium potassium ATPase and lots of others. So it probably has an effect from that point of view in terms of membrane stabilization because it acts at that sodium potassium ATPase. But the true story is that actually no one really knows how it works from an antiarrhythmic point of view, but we use it quite a lot and it's quite safe. So yeah, but that's why it doesn't fall necessarily in this table because its mechanism of action isn't really known. Okay, I can't remember why I put this in here. Oh yes, that was it. So this again I've lifted, but it is quite useful. So there's a couple of papers published recently in BG Education on arrhythmias and antiarrhythmics, which are really well worth reading. And they've got this really nice diagram, which I'm not going to go into now, but just to remind me to tell you that actually this splits it up into where the different classes work and at which phase. So you can then think about if there's something going on, what you might use to treat it. All right.
There's a difference between the cardiac myosin action and the action of the nerves. That's right.
Yeah. Everyone happy? Yeah. Okay, so in summary, we've gone through a bit of the basic cardiac electrophysiology and the pathophysiology and a bit of a rationalized approach to management. And remember to apply a structure management strategy, taking into account the underlying cause, because that's probably the main thing, and therefore what the consequential anemia might be. And the point of this is that the majority of the time, you don't need to give everyone amiodarone to treat their arrhythmia. It's like using a hammer to crack a nut, because amiodarone works on every channel, doesn't it? And it is a fantastic drug for critical care, but for long term, it's awful. All right, because it doesn't really address the underlying issue. Exactly. Yeah. It's well, there's probably lots of different reasons for that. Partly risk benefit analysis is most of the time you're using amiodarone in ITU, it's been an emergent. A lot of the stuff with thyroid is actually a long-term consequence. In fact, it is a long-term consequence down the line in terms of its effect on iodine and thyroid function. And the other thing is that actually checking thyroid function in an ITU patient is almost pointless because you have no idea what it's going to be. If it's high or low, you can't really interpret it, and therefore you're probably better off just not doing it. That's probably the reasons. So yeah, I've put and you guys are welcome to have the slides, but those are the two papers that are well worth looking at. And actually this anesthesia website, which I've not come across before, is actually really good. Just explains things quite simply, and that's where I lifted some of the diagrams for, and shameless self-plug in the cardiovascular system chapter in Smith and Aikenhead that I helped write. Cool. So yeah, I mean, I'm a big believer anyway in understanding first principles, because you can apply stuff to that, and it makes, if you can understand first principles, then everything else is easy, rather than just listing it. Remembering a huge list of different drugs and what channels they work on, it's so difficult. So yeah, that's everything I wanted to say. Any questions?
Yeah, I've got it. And is the only unit you say on?
Oh,
On phone.